The question were, thank you for asking me to talk today, and kia ora everyone. What I'm going to try and do is take us on a bit of a journey, a global journey that aims to rethink just a little bit how we might approach the framing we have around young people's health and well-being. The second decade of life is often overlooked in research terms, but it's a critical one for an individual's development and future outcomes. Not least of all because we now know brain development is significantly impacted by the social environment during adolescence. So what I'm going to hopefully illuminate for you is a theoretical framing that can essentially based on a strengths-based approach that can help us frame interventions and meaningful action from a public health perspective to support young people. So a central premise of what I'm going to talk about is that health policy developments have often focused too much on the failure of individuals and local communities to avoid disease, rather than their potential to create and sustain health and continued development. And this is a popular discourse at the moment. You will hear a lot, and I'm sure we've all used it, what we need is a strengths-based approach. But it's rarely articulated actually what that looks like and how it can be actioned, and what are the components that really need to be incorporated into a strengths-based approach to enable it to be effective. So I want to start first with these two images. This is the steps of a favela in Brazil that I walked in 2018. During 2017, 2018, 2019, I engaged in some work with the University of UFMG in Brazil, who provided health services to the community. One day I went to visit the clinic and services that have been developed to support the local community by the university. To walk the steps of the favela is an act that both requires permission of the local drug lord, and in this case was a test of support and willingness to respect the community. What you can't see, and I certainly wouldn't have taken pictures of it, is that in the next minute, a number of very young men with semi-automatics and very sophisticated technology would stand on that wall in the first picture and talk, fortunately, entirely amicably with myself and the university team. But the technology and the living conditions, and the second picture is the first house in the favela, formed a stark juxtaposition. There are a number of things that I need to tell you that give you context to these images. The population of the favela is predominantly young. The young men on the parapet, the wall up there, laughing and joking with the doctor leading the team, were easily under 18. While the population of Brazil is largely Portuguese in descent, and particularly in the city we were in, there is a large park in the centre, a beautiful kind of civic park in the centre of the city. But this in the 17th and 18th centuries was actually a slave farm that supplied African slaves to the country. The descendants of these slave farms now dominate the population of the favela. The lives of the residents in the favela are predominantly defined by two forces external to the country. Firstly, the cocaine drug trade that supplies the USA wealthy who take cocaine and beyond. And the returning trade from the USA, often legally bought guns that lead to a low life expectancy among young males, particularly in countries like Brazil and Mexico. Now, I share these images with you not as voyeuristic images to demonstrate how terrible these communities' problems are, but to ask a question. What in this context can a programme of public health do? And what are the processes and factors that need to be considered by those who have the resources and power to actually enact change? Just to let you know, by the end of this talk, I will share with you how the support and empowerment that was given to this community by doing just that. So when we think about addressing the kinds of problems that young people and challenges in these in the favela face, it's often been framed by a deficit model, which focuses on identifying problems of populations or groups within populations. This requires extensive professional resources, resulting in high levels of dependence on hospital or welfare services that focus on risk factors and disease, and even lead to saviour models that empower professionals but not communities. Individuals and communities within them are often identified as failing to make adaptive changes towards health and are labelled and stigmatised. This is a particular issue with young people. Young people are repeatedly, in the majority of countries, positioned as a social problem to be fixed. Just in the little breakout room we were talking about how in the press today, there's quite a lot about the crimes, that young people committing crime in this country and how terrible that is. That kind of discourse about young people are to be feared and are a problem is a very common one, particularly across the West. So this is the report actually that got into the press about my own research. So British teens are the worst behaved in Europe. 15-year-olds are more likely to get drunk, be aggressive and sexually active than their peers on the continent. The misery of youth, teenagers depressed and fearful as drink, drugs and crime take their toll. In fact, the findings actually, I never actually said any of that, but it was interesting that that was the positioning the press took to take. So for young people navigating adolescence, this whole positioning of them can lead to an increase in societal rejection of young people. Teenagers' social problem means that they are other, and even being on the street is then becoming problematic for them. How many adults, when they see a group of young people on the street, cross the road rather than walk past them? A survey across Europe and North America that was done on this showed that a very high proportion of adults do exactly that. This kind of discourse prevents questions being asked about what promotes young people's health and well-being from their perspective, and what should policymakers really do to promote their health. So I want to share with you briefly some findings now from some work that I've been involved with, and it's the Health Behaviour in School-Aged Children study, and I've been the chief investigator for a number of years now, for about a decade, for the UK part of the study. This involves over 200,000 young people every 4 years being surveyed across Europe and North America. And now we have parallel surveys in countries such as Taiwan, China, Japan, Korea, have all taken, and countries in South America. So we survey young people aged 11, 13 and 15 on over 60 topics relating to their perceptions of their health and their social and environmental context. So we ask them about everything from the traditional health risk behaviours to how they see their parents, their family and their community life. And this study has been going and is supported by WHO, and it has been going since 1982. So there's a long series of cross-sectional work. It's a snapshot of each generation. The issue we want to challenge with the health behaviour in school-aged children is that in young people's health, the deficit risk behaviour model has dominated. If I asked you kind of what are the main health issues that young people face, it often relates back to things like smoking, drinking, drugs, crime, fighting, early sexual initiation, or just sexual initiation and sexual activity even. This quote from a UK Minister of Education is kind of typical and sums it up. If young people stop participating in health risk behaviours, they'd all be happy and they'll all get A's at school. However, over the last decade, we've seen attention to risk behaviours being very significant. And many public health initiatives have actually been very successful in reducing, for example, smoking behaviour amongst young people. As this chart shows from 2002, we can see for 15-year-old boys, smoking, drinking, drug use, cannabis use, and fighting across all age groups has declined. If we look for girls, we can see the same pattern. And this is across Europe and North America. However, life satisfaction and well-being has not tracked in the same way. So the top chart here shows the life satisfaction reported by 15-year-old girls across the countries that are part of the study, and the bottom chart is boys. The more pink and orange, the higher the life satisfaction. And you can see that for girls, there's only really one country that gets into the top rating, and that's the Netherlands, where there's high levels of gender equity. And for boys, have a much higher levels of life satisfaction than girls across all the countries. At age 11, this chart would look almost identical for boys and girls. So something happens during adolescence, particularly to impact negatively on girls' life satisfaction. Girls' life satisfaction during the second decade of life, we know also equates very highly with life satisfaction in adulthood as well, and to a certain extent, positive life outcomes. Self-harm, while all risk participation in risk behaviours has declined in the traditional ones, self-harm has dramatically increased, another indicator of poor emotional and well-being and mental health amongst young people. So in the last round, and we do survey 15-year-olds in the UK on this issue, in the last round, 33% of 15-year-old girls reported that they had ever self-harmed in the last year, and 17% of boys. And this is, we first undertook this element in the survey in 2014, and then in 2018, and we are currently in the field again doing this survey work. So you can see the dramatic kind of increase that we've seen over the decade since the early work by Horton in 2002, where he found 13% of young people. At the same time, we've seen these kind of trends emerge. The young people's participation in positive health behaviours, those that are protective of your well-being, have kind of flatlined, or in many cases gone down. So, and this is typical of most countries, these kinds of proportions of only 18% of boys and 13% of girls meeting the recommendations for physical activity to maintain health and well-being on a weekly basis is typical of most countries. And you can see that, you know, no matter what we've done, it hasn't impacted particularly on girls' participation. The little peak we see in 2010 is from the UK, where there was a extensive attention to boys participating, particularly in football. There was lots of outreach programs that improved the physical activity of boys at that time. But subsequently, funding for that has been reduced, and we can see the subsequent decline. Okay, so that tells us that actually a focus on risk behaviours and a deficits framing isn't going to attend to young people's health and well-being. So at this point, I want to take you into a little bit of a journey around salutogenesis. In 1979, Aaron Antonovsky, who was a Jewish Israeli scholar, and some of you attending the seminar I'm sure will know all about Antonovsky, introduced the concept of salutogenesis. And he was looking at survivors of the Holocaust, and as might be expected, given the circumstances, many Holocaust survivors endured. They went on to have very problematic life experiences. So often, you know, reported poor health, problems with forming relationships, and substance misuse. However, there was a cohort within Antonovsky's sample who reported they were thriving. They reported having very positive relationships and went on to have successful, by any definition, successful lives in terms of their relationships, their family lives, and their careers. And he concluded from that 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 statistically insignificant, as he said, cohort, but statistically significant cohort in terms of understanding what causes health, was that they had aspects or protective elements that enabled them to navigate their circumstances and still believe that the world was manageable and navigable by them. So he argued that instead of thinking about what prevents starting from disease to determine how individuals can avoid and manage and eliminate disease. Salutogenesis enables us to work prospectively by considering how to create, enhance and improve physical, mental and social well-being. And from this, develop the assets work. So a health asset can be defined as any protective factor or resource which enhances the ability of individuals, communities and populations to maintain and sustain health and well-being. And Morgan, who did the early work around this, argued that the more we provide young people with opportunities to experience and accumulate the positive effects of protective factors, health assets, the more likely they are to achieve and sustain health and well-being now and in later life. So this takes a very different approach to many of the resilience programs, which are, for example, 6 weeks programs delivered in schools where young people are taught to be resilient or gritty, as many of the positive psychology approaches would take. And then at the end of that program, they're then expected to be resilient and able to cope with everything that life can throw at them. The assets approach says, well, actually, that's going to be impossible for many young people. And what we need to think about is the protective elements that we need to enable young people to marshal their resilience and marshal their internal assets and actually thrive. Work of Scales in the USA identified 40 developmental assets that were critical to enabling young people to thrive. And this was family relationships, caring, school support, the empowerment, that they were in a community that valued youth and where young people were seen as a positive resource for that community, that they had access to mechanisms for constructive use of their time, an ability to access learning, positive values. They were enabled to access and develop positive values around caring and being responsible to others, social and cultural competencies and access to cultural resources, and positive identity, self-esteem. But these really represent only a starting point, because as I'm sure you can see from those first images of the favela, many young people do not have access to these in a cumulative way. So we need to move away from a simple additive list, the more the merrier. The more assets you have, the better you are, because essentially that just simply equates with being middle class. We need to increase connectivity. We need between assets theory and the material realities of people's lives. So how can assets actually help people no matter what the circumstances they're in? And simplistically prioritising social cycle factors could construct a potential for victim blaming, to underplaying how broad social determinants construct health and life outcomes. So we need an assets framing and a strengths-based approach that actually works with the broader social determinants of health. And as more recent work has actually argued, assets most meaningfully manifest only in the transaction between the person and their environment. So we have to come up with a framing and actions that actually engage with the environment. So in the work that we've done with HBSC, we've been evolving a model that works in this way. So we look at physical assets that people have in their environment, support them. This can be community resources, their access to being able to be on the street, sports facilities, a whole series of physical and community assets that could be available to them. Social assets, which include cultural resources, support from families, belonging to school, belonging to community, cultural resources. And then psychological and emotional assets. And that all of these three work together. So the internal assets, the self-esteem, the identity that young people develop are created through an interaction between these other two domains of assets. It's then argued that if young people have access to these kinds of assets, that strengthens for them a sense of social inclusion and strengthens for them a sense of social cohesion, feelings of safety, trust and belonging. And we know that feeling safe, for example, at school, or a sense of belonging to school or belonging to your community actually enables young people to be much more successful in educational settings, for example. And then having access to a sense of social inclusion and social cohesion, it improves overall well-being. So it improves across the domains of well-being: mental, cultural, physical, spiritual, and sexual. And then this contributes to a sense of health and access to health as a resource. However, we now know there are key elements, and the more recent work we've been doing, we are arguing that there are key elements even missing from this model, which brings me back to Brazil. These are images from the community work that was being done in Brazil. The starting point from the university workers that I work with was that there would be no hierarchy between the workers and the people in the favela and the community. And I think you can see from these images, and certainly from the bottom image, you probably couldn't tell who's a worker, who's part of the program, and who's a member of the community, except probably the young woman here, very proudly holding her first child. What the university also did and recognised was that without access to economic independence, particularly the women in the community, would never be able to thrive and support their families. So not only did the university provide health services, they also collected things like jewellery, used jewellery, and enabled the women to recraft it and sell it in the local market. So they had access to economic resources as well, and development of economic skills. From that grew a sense of engagement, grew a purposeful series of engagements with young people, and the ability to take over and get funding for a major resource within the city. And what young people articulated that they wanted was an outside space inside. Because being outside in the community is not safe. You are highly likely to be targeted by the drug gangs and forced to join them. So what the young people created, and were very strong about creating, was that need, which an adult, and I as an adult, and the adults in part of the program would never have thought about, was the need to feel that they were outside, hanging about with their friends, but in a safe inside space. The young people also defined that the kind of library they wanted would be a comic library. And so they now have access to some of the best comic resources that's possible probably in the whole city, and probably most of Brazil, the workers argued. So this was all defined by the young people themselves, and the sorts of spaces they wanted to have access to, and the resources they wanted to have access to. The young people also were facilitated and supported to decorate the facility themselves. So it was designed by and a place where, in terms of the images that they used on the walls, it reflected themselves and their communities. So this beautiful, which is about 15-foot high image on one of the walls, is an image of an indigenous person from the area, young woman from the area, and it carries the names of the community members who painted her. So this is a space that, and some of those young people who use that space every single day, because it is the only space available to them where they can feel safe, and therefore can access resources that maintain and create pathways of action for their health. So the additional element we feel that assets framing and strengths-based framing needs to take on board is a sense of political action that enables asset mobilisation, where young people's participation in analysis, interpretation and direction of projects and data is fundamental to that process. And it takes on board the critical theories of change in terms of proportionate universalism. Not every young person is going to need an inside space that is actually an outside space, but for these young people, it was critical to their health and well-being. So we need to take on board the core elements that are often forgotten about the Ottawa Charter, and that is our responsibility is to enable, mediate and advocate. And I'll finish there. Thank you very much.